Hi, Artur. I'm joined by Artur Fedorowski, who is really kindly going to answer some questions. Artur is a cardiologist. I think perhaps it's your best to tell us what you do. And then also, after you've said what you do, could you just give us a bit of insight into the research that you've been doing lately regarding long COVID?
So I'm a senior consultant at the Department of Cardiology at Karolinska University Hospital in Stockholm, and associate professor in cardiovascular medicine from Lund University, also in Sweden. For last 15 years, I've been doing research on cardiovascular autonomic dysfunction. Especially in the last 10 years, I've been doing a lot of research on postural orthostatic tachycardia syndrome, starting an investigation unit and laboratory, including tilt table testing and other cardiovascular autonomic tests at Skåne University Hospital in Malmö in Sweden. So I moved to Stockholm quite recently in May this year to start a similar unit and to start a research activity in Stockholm.
Wonderful. And you've just recently co-authored a paper about tachycardia syndrome post-COVID specifically.
Yes, that's right. I must admit that we didn't see it coming. And when the pandemic started, it was all about infection and fatal cases of COVID-19 among all the people with multiple diseases that were hospitalized in ICUs, intensive care units. And we didn't see it coming that our research area will be so popular just because of COVID-19. Starting in September last year, 2020, we started seeing patients coming to our outpatient clinic with symptoms that were similar to those observed in postural orthostatic tachycardia syndrome. Then I contacted my colleagues in Stockholm, or rather they contacted me because they started a post-COVID clinic, the first post-COVID clinic in Stockholm, as the first wave of COVID-19 pandemic washed over Stockholm as the first place in Sweden in March, April 2020. So they started seeing very strange patients who had never been hospitalized, and usually younger, relatively younger women in their 20s, 30s, 40s, who complain of being totally incapable of working anymore, with orthostatic intolerance, with rapid heartbeats. So they contacted me and they asked me, have you ever seen these guys? You've written so many papers on postural orthostatic tachycardia syndrome, POTS. Who are they? So our collaboration started at this moment, and exactly, I may say that it happened just 1 week after our first initial talk on phone. I saw my first post-COVID POTS patients. So this is how it started in the mid of September 2020.
Wow. So how many patients do you think you've seen since then?
In total, I would say it's hard to calculate, but I would say about 50 to 100.
Yeah.
That I have seen personally at outpatient clinic.
Yeah.
But my colleagues have seen at least as many.
Yeah. I think, I mean, personally for me, I'm sort of 8 months down the line now post-COVID, and probably 2 months after the initial infection, I started to realize that something was wrong with my autonomic nervous system. Kind of stuck in that fight or flight zone, if you like, stuck in sympathetic. And then, we are, as you know, running a support group for long COVID patients, and we've got nearly 12,000 in the group now, and we started to talk to each other about it, and so many of the group have the similar symptoms of, you know, dysautonomia, POTS, autonomic nervous system dysfunctions. I would say like a vast majority have those symptoms, and there's nearly 12,000 members, and it's a lot of people. You know, when you've got that anecdotal evidence that it's obviously happening as well. What do you think the symptoms associated with specifically post-COVID tachycardia syndrome, as you've defined it, how do they differ from POTS?
So I think that we should go back to 1993, to Mayo Clinic, and the group of Mayo Clinic, Dysautonomia group, led by Philip Lowe. And the first paper published on POTS, it described young patients, preferentially women, young women, with orthostatic intolerance, rapid heartbeats, and other symptoms of autonomic dysfunction in the other organs in the body. And they described only 16 cases, actually, as far as I remember. And more than half of them got this problem happened weeks prior to the onset of these symptoms, which of course give us an indication that the original POTS, or the syndrome described in 1993, was quite similar to the phenomenon that we are observing right now in the wake of COVID-19 pandemics. So I don't think there is a huge difference between the old POTS described in 1993 and this wave of new post-COVID POTS patients in the wake of the current pandemics.
Okay.
These are the same patients, maybe with some minor differences in some subtle symptoms that are more expressed. But these patients complain of tachycardia, which is very characteristic. This abnormal tachycardia, as soon as you get up, is very characteristic. And it was exactly described by the original paper from 1993.
Yeah. Okay. So are you treating it just the same way as you would treat POTS then? So with the post-COVID patients, this tachycardia syndrome, just the same sort of treatment for everybody?
In 2008, when I saw my first POTS patients coming to our syncope and dysautonomia clinic in Malmö, I must admit that we had no idea how to treat these patients. I had no idea, and we just started trying out different drugs, different medication, different procedures, just trying to find the best solution. So at this time point, we had nothing that we can use against this disease, and just through a process of experiment, trying out different options, we found out a sort of cocktail of different drugs that work very well. So now, having to do with this new wave of POTS patients, we just apply this old medications, this old cocktail onto the new group, and it seems to work very nicely. So we're just using old POTS medications against this new phenomenon, and it seems to work very well against cardiovascular symptoms. However, there are other symptoms associated with POTS. We should not forget about brain fog, deconditioning, symptoms from other organs, chest pain, problem with breathing, and so on. And this is very difficult to get to these symptoms, to get them.
Okay, so the medications are just addressing the sort of cardiac side of it, and not the other symptoms.
Yes, of course. We are talking about drugs that were used against tachycardia for other reasons, against hypotension for other reasons. So we just combined the old drugs and fitted them into the new syndrome, and it works. And the cardiovascular area is well explored as far as pharmacological options are concerned. That's why we have access to these different drugs. Whereas when we're talking about brain fog, actually there are no good drugs against this symptom.
Okay, yeah. So in terms of, I guess, kind of prognosis for those of us who are struggling with POTS type symptoms and all of the other things that come with that, do you think there is a likelihood that this will improve over time, or there's going to be more treatment available? I think a lot of people were asking the question, you know, how long are we going to be like this?
Well, I think that patients that I met initially in my career, in my doctor's career, were just old POTS patients that did not recover. So they were just circulating within the healthcare system, and then in the end they found me. I was interested in it. I could diagnose it, so they found me and they asked me for help. But there must have been a lot of patients having these symptoms for some time, this initial symptoms that were worrying for them. They went from one doctor to another who could not diagnose them in an appropriate way. And some of them were lucky enough to get rid of it. So we see the same phenomenon with this new wave of POTS patients. There are many who get temporary symptoms, or symptoms that decline in due course of time after 6, 7, 8 months. However, there's a huge group of patients with symptoms that do not decline, that do not improve over time. And I think that this is the group of chronic POTS symptoms that we'll have to deal with.
Yeah, okay.
And if you ask me for numbers, people used to ask for statistics to know what the chances are. So in my personal experience, we're talking about 50-50 chances. If you get POTS after COVID-19 infection, I think that you have 50% chance to get rid of it over a period of one year. But there is, unfortunately, there is some likelihood that you will get some chronic symptoms as well.
Yeah, okay. And I guess then it's just about, you know, medication and lifestyle and the things that you need to do to try and keep those things under control.
Well, they can improve the prognosis, but on the long run, I think that there must be some genetic predisposition that makes some people more susceptible to chronic symptoms and some people more susceptible to spontaneous recovery. Yeah. So it's all about our lifestyle plus some genetical preconditioning, I guess I would call it.
Still more research to do then.
Still more research to do.
Okay.
We have noted that some POTS patients have a special kind of human passports, HLA system, which is a sort of recognition system for immune cells to know that these guys are good, these guys are ours, we don't touch them. But for some reason, the autoimmune system does not recognize your own cells, and through this HLA system and attacks your own body, your own cells, which we call autoimmune disease. So some people have special variants of this HLA passport cell system that can make them more susceptible to autoimmune diseases, which we believe POTS is essentially.
Okay, all right. So let's get onto some more of the group's questions. So are there any long-term complications that could be caused by exercising when we're in this state? Is there a risk of overdoing it and that causing further damage, or is exercise a good idea?
It's quite a difficult question. I think that I would make some comparison with obesity. If you are a little bit obese, a little bit overweight, so training can make you feel better, can make you lose your weight, and can improve your prognosis. If you are very much overweighted, then if you start training, so which is very intense, you may overload your circulatory system, which may lead to some consequences, heart failure, heart attack, and so on. So there must be some limit. This is very, this is good. This is profitable if you do it unto one time, unto the point that your body can tolerate it. Yeah. If your body cannot tolerate it, it may cause more damage than advantage.
Okay, thank you. Yeah, that's really helpful actually, because I think a lot of people are frustrated because obviously a lot of people that have this were previously very fit and healthy and exercise frequently and are becoming frustrated and not being able to do that anymore. So I think your advice is perfect actually, just to keep it within your level of tolerance and keep a really close eye on yourself afterwards to see if you feel well.
Yeah, yes, but there's hope. If I can interrupt you this moment, there's hope in this as well. Just please imagine people with overweight, so who are very strongly overweighted. They can undergo surgery. They can reduce their body weight, and then they can start training. So in this case, with POTS, if we can treat these people who are very heavily struck by the disease, we can push them back to the point where they can start doing training, performing training, and physical training, and they can improve by themselves from that point on. So we have to push them with our medications, with our procedures, and then they can help themselves on the way further on.
Brilliant.
So nice this is our hope for future.
Yeah, it's always good to have some hope. Okay, so I think that kind of answers the other question as well, is why the link with fatigue and sports, and why does the body react badly to light exercise? And I guess you've answered the question in that you're just not ready to exercise to that extent yet, and we need to pace ourselves more if that's the case. Yes.
Yes, that's right. That's correct.
Okay. So what tests should we be asking our GPs? And if we are fortunate enough to, there's a lot of the group are having problem getting to even see a cardiologist at the moment. I think you're all overloaded, too many patients. But if we do get to see a cardiologist, what tests should we ask for?
I would propose that you ask for an active standing test to demonstrate that your body reacts in an inappropriate way, that your heart rate increases too much on standing, not just by 10, 15 beats per minute, but by 30, 40, 45 beats per minute. Then you can show a diagram from your watch with pulse tracking. If you have special training watch that can track your pulse rate, then you can show the diagram to the doctor and saying, oh, now I'm sitting, now I'm standing, and you see the difference. Please, can you explore it? I know there are some diagnostic methods that can confirm that I have POTS. And then you should emphasize that these symptoms are chronic, continuous. This is not just a question of anxiety or that you feel tired, that you have bedridden for a few days, few weeks. This is something that is there by itself. Yeah. And then you might ask for more sophisticated tests, just like cardiovascular autonomic testing, tilt table testing, or 24-hour ECG monitoring, which we call Holter monitoring. On Holter monitor, you can track the heart rate changes over a 24-hour period. And on 24-hour Holter monitor, you can see the spikes of your heart rate. Anytime you get up, you get down, get up and down, and then you go to bed, heart rate goes down. And then in the morning, then the doctor should focus on the morning hours. And you can see this impressive heart rate increase in the morning from 60 to 120. And then it keeps just being high or increasing during the day. So then you can see this is not normal. You can see, you can tell your doctor, this is not normal. I promise you, I talked to another doctor who knows it very well. Another guy from Sweden, Fedorowski, told me this is not normal. You should believe him.
I'll make everybody say that.
You can use my name.
All the doctors are going to be cursing you.
They will be cursing me, sure, I'm sure. They are doing now, probably.
Probably, yeah. So, as well as medications, what natural treatments might be helpful for people to bring their autonomic nervous system into balance?
Oh, when you set natural measures, I'm thinking about increased fluid intake, maybe increased salt intake, maybe some special garments, compression garments that you can use. These are the measures. So getting back to natural methods, I would recommend increased fluid intake, especially in the morning, slightly increased salt intake if you have low blood pressure, then compression garments, something that I would recommend, and physical training your musculature, especially in the legs, in the rest of your body, by tanning your musculature. You can increase your so-called venous blood return to the heart from the lower part of your body, and decreased heart rate as well.
Okay.
So there are different measures that you can apply by yourself to improve how you feel. However, if the problem is too complicated or too advanced, then you will need some drugs as well. And we have drugs that increase blood pressure, that can lead to constriction of the vessels, especially in the lower part of your body. In POTS, what we have observed is that the blood is accumulating not only in the legs, as well in your belly as well. So that's why we recommend very high compression garments going up to the abdomen level, to the stomach level.
Okay.
So you have drugs, and especially you have drugs that control the heart rate, which is very important. If you can control heart rate, the feeling of fatigue will diminish as well.
Thank you. So, with many people suffering anxiety symptoms, heart palpitations, being sent for ECGs, and then getting results that are considered normal, are you aware of anyone looking into the possibility that damage to or overstimulation of the adrenal glands is at all responsible for any of these symptoms?
It might be. We don't know for sure yet. We've been working on another hypothesis. So our hypothesis is based on the assumption that this is a sort of autoimmune disease, autoimmune response. But the target for the autoimmune response is not different organs, different cells, but the target for this specific autoimmune response are cardiovascular receptors and other receptors that are similar to cardiovascular receptors. We call them adrenergic receptors and muscarinic receptors, first of all. So adrenergic receptors are the receptors that control heart rate and the tension of vessel wall and how the body reacts to stress and so on, standing position. What we guess is that these special autoantibodies that are built by the immune system in the body they modify how these receptors work, making these receptors more sensitive to natural neurohormones, like adrenaline or noradrenaline. And instead of reacting in a normal way, you just press the gas to the bottom, if you know what I mean.
Yeah.
Just instead of just running 20, 30 miles per hour, you're just driving suddenly 70, 90 miles per hour without any need for it. So this is what makes people feeling as well anxious, well, worried. What's going on with in my body? You're feeling like you're running marathon every day.
That's a really good analogy, actually. It feels like a marathon every day. But okay, thank you. Well, keep us posted on that then, on the research. We'd love to hear, obviously, when you're looking further into that hypothesis.
But I would like to make some comment on it, a warning sign. The problem with this test is if you test yourself for the presence of autoantibodies, usually whether they are there or not, you will not see so much that makes sense. Because even healthy people may have these autoantibodies. And if you test yourself for the presence of the autoantibodies, you will get the answer from the lab, some of the labs that are doing this normal, usual commercial test that, oh, you have this autoantibody. Then you start believing, oh, I have POTS. POTS is actually diagnosed on the basis of your symptoms.
Yes.
But this is another story, the presence of these autoantibodies. But they are very special in the patients with POTS. They do something wrong with your body that the autoantibodies in the healthy people do not. So this is the major difference. So what we are doing is we are looking at what they do, which is wrong.
Okay.
Not whether they are there or not.
Yes, makes total sense. Thank you. Yeah. Okay. Somebody has asked, can nerve damage heal, or will we always be a bit, and she's phrased it, tweaky?
Interestingly, we have never seen patients with POTS developing heart failure and some damage in the heart muscle. We haven't seen it. And the question is whether this heart rate, which is increased, does not affect your heart muscle as long as you are so young. Or whether this disease will get a little bit quiet over the years, because your heart rate will decrease over the years. Your maximum heart rate will decrease. And we have a way to calculate it. If you subtract the number of your age years from 220, then you will get your maximum heart rate.
Yeah.
As you can guess, if you get older, so the maximum heart rate will diminish.
Yes.
Maybe this is something that is limiting for POTS as well. So if you get older, you will just get rid of POTS by the natural way. But the problem is probably that you develop another problem, another condition, which we call orthostatic hypotension. So instead of getting a very high heart rate, you will get very low blood pressure or blood pressure fall on standing. Yeah. So this is what we think is the natural way of developing POTS. And then when it develops into orthostatic hypotension, this is the hypothesis, but we haven't observed POTS patients over such a long period of time.
No.
I've been seeing them for, like, let me see, 12 years now.
Yeah,
so
it isn't a long time, is it, really?
They are not very old yet. Probably I'm gonna die before them.
It's teaching us patience, isn't it? That's for sure. Okay, I'm just going to do a couple more questions because I think that people with brain fog, etc., are going to struggle to watch for too long. And I think we're probably approaching an hour, are we? Anyway. So Let's have a look. What can we see here? Oh, so we had a question from another cardiologist, actually, and he has asked, what are the most common autoimmune markers that you are testing? Which are most commonly positive?
Autoimmune markers. So there are no good autoimmune tests as yet. I mentioned autoantibodies against cardiovascular receptors. We call them G protein coupled receptors. And there are no good reliable tests commercially available. However, we're working on it, and probably we should be able to provide them within a range of 2, 3, or maybe 4 years from now.
Okay. As
far as other autoimmune markers, there are no reliable markers of POTS, but some POTS patients may have autoimmune markers of other diseases, just like Sjogren's syndrome, lupus, or gland thyroid autoimmune diseases. These markers may be increased. And it means that having POTS increase your probability of having other autoimmune disorders.
Yeah, okay. Yeah, that makes sense too. Thank you. I think that probably if we leave it there, I might just be cheeky and perhaps we could have another chat another day just to cover some of the other questions, if that's okay, just a brief one. Would you be okay with that?
Absolutely.
Make this a two-part.
I would be happy to answer your other questions, to address your other issues.
That's brilliant. Thank you. So maybe just leave us with, there is some hope. Yes, that we won't feel terrible forever.
If I may say something now, which may sound a little bit controversial. So I think that COVID-19 pandemics might be very beneficial for POTS patients, because the attention was directed onto this group of patients now. And now everybody is talking about POTS.
Yes.
At Karolinska Hospital, everybody is talking about POTS.
Yes.
It was not so before.
Yes.
So there is hope. Just the pandemic might be a sort of blessing for POTS community. Let's see what happens next.
And we see that on social media a lot, you know, people with POTS, with ME, CFS, you know, with mast cell activation syndrome, which I think we probably need to address next time. These people are also kind of grateful that the spotlight is now on them as well, because there's so many of us with COVID who are suffering the same as they have been for years. So let's hope that it does bring some help and treatment for everybody.
Yes, I agree. I definitely agree. I definitely agree.
Thank you so much, Artur, and we'll do another part 2 coming soon. Okay.
Well, thank you for inviting me. It was really a pleasure talking to you.
You're welcome. Thank you.